It's 10 o'clock, so we might get started. Okay. Well, hello, and welcome to everyone. This is the first seminar in the Holsworth Research Initiative Seminar Series for 2022. My name is Courtney, and I am the Research Coordinator for the initiative. I'd like to begin just by acknowledging and extending my appreciation for the Dja Dja Wurrung people, the traditional owners of the land that I'm hosting this seminar on today. We pay our respects to leaders and elders, past, present, and emerging. I also acknowledge the traditional custodians of the various lands from where you all join me today, and of course any Aboriginal and Torres Strait Islander people who are participating in this seminar. The Holsworth Research Initiative would not be possible without the generous support of the Bendigo Tertiary Education Anniversary Foundation. We thank the Foundation for their ongoing support, and I extend an extra special welcome to any members joining us today. Just prior to starting, I'd like to talk briefly about some minor meeting etiquette. If you could please ensure that your microphone is on mute throughout the presentation. There will be an opportunity to ask questions of Monica at the end of the presentation. So also, if you'd like to, you may use the chat feature throughout the presentation as well, if you've got any pressing questions. So I'll now hand over hosting duties to Dr. Rodrigo Beni. He is the HRI Human Performance Stream Lead, and he will go ahead and introduce our guest presenter for today. So I really hope that you enjoy our seminar. As I said, this is the first seminar in a series that will run throughout 2022, and we aim to engage international guest speakers who are leaders in the fields of exercise, physical activity, and rehabilitation. If you'd like to be notified of any upcoming seminars, please visit the HRI website and subscribe to our newsletter. Thank you again for joining us today. I hope you enjoy the presentation. Over to you, Rodrigo.
Thanks, Courtney. Thanks everybody for joining, and really would like to thank particularly Monica for accepting this invitation to get us started on this new activity, or expanding some things that we have been doing on this space. And just to give everybody a bit of a sense, Monica, she's an associate professor and director of the Mobilize Clinical Biomechanics Laboratory in the Department of Kinesiology and Health Science at the University of Waterloo. So thanks again, Monica, for talking to us, particularly very late in your day. I know that you have been through a lot and you're still holding on strong to actually give us a very nice presentation. Monica's research goal are to promote physical activity among adults with osteoarthritis and provide strong training experiences for academic and professional students. She's using biomechanical methods and imaging to evaluate the impact of physical activities on joint health, mobility, and productivity. And the work that she's done has been supported by the Natural Sciences and Engineering Research Council of Canada, the Canadian Foundation for Innovation, the Arthritis Society and Canadian Institutes for Health Research, and the CIHR Institute for Musculoskeletal Health and Arthritis. Again, thanks, Monica, and I'll hand over to you now.
Thanks so much for such a kind introduction, and I am so pleased to have this chance to share with all of you. So thanks to everyone for joining. Thank you so much to Dr. Beni for the invitation. And yeah, I'm so pleased to get started. So let me just share my screen. I'll bring this up. And are you able to see and hear what you need to? Awesome. Okay. Well, I'm so honored to participate in this seminar series. And before I get started, I will do my land acknowledgement. And bear with me, sometimes I have a hard time with this particular slide. I want to acknowledge that all the work that you're going to hear about has been conducted on lands that are the traditional territory of Indigenous people in Canada. There's a little locator on the map here, and that indicates where the University of Waterloo is placed. And you'll notice that it sits on lands, and these lands were taken from the Haudenosaunee people in Canada. Now you'll see a shaded area. This follows the Grand River, and this shaded area was promised by settlers to the Indigenous people in a treaty created in 1784. What you'll notice is a red area, and that is all that remains honored from that treaty. This represents a loss of 900,000 square kilometers of land from the Indigenous people. Within that red area sits the very first residential school that was opened in Canada. And across Canada, we estimate that at least 150,000 Indigenous children were forced to attend residential schools where we know that they were abused. Right now, underway is an investigation of unmarked graves at that school site across the nation. So far, we have identified 1,300 children who've been found in these unmarked graves, and we know that that number will grow. I just tucked my little one into bed, and he is safe. So it's really hard to share that history, but so important to do so. So thank you for listening to that. So here I've zoomed out so you can find the University of Waterloo within Canada, and on a much happier first that I can share. In 1967, UWaterloo was the first in the world to host a Department of Kinesiology. And since that time, we've grown to about 30 full-time faculty who support undergraduate and graduate education, a school of anatomy, and a co-op program to give our students experiential learning. In the bottom right, you'll see a picture of my lab where we're conducting some motion capture in that photo. And I feel really privileged to be able to share some of the work that's come from that space with you today. And so what my plan was today was to first give an update on osteoarthritis disease. This is the focus of the work in my lab. And after that, I'll spend some time telling you about some of the studies that we have conducted that look at linking biomechanics to joint tissue health and joint tissue damage. Importantly, I'll try then to connect that work, those biomechanical findings, to strategies to advance exercise for people living with osteoarthritis. And so here we go. Arthritis is the greatest cause of chronic disability among adults living in the community. And that's true in Canada, and I'm sure that's true across westernized countries. The reason why it has this dubious title is because it's so prevalent. In the next 5 years, we expect 10 million Canadians will live with some form of arthritis. And among those, 1 out of every 3 will be unemployed. Even more concerning, compared to their peers, people who live with arthritis are 3 times more likely to have to depend on someone else to get through their day. And we think we're spending almost $18 billion a year on this condition. Now, out of the many different forms of arthritis, by far the most common is osteoarthritis, or OA. 20 years ago, we considered OA to be a wear and tear disease that essentially we just kind of wore out cartilage tissue in joints. We viewed this disease as non-inflammatory. And so the way we would identify OA was usually through radiographs, and we'd be looking for things that kind of demonstrated this loss of cartilage. So loss of joint space, joint deformities, and osteophytes, which are bony growths around the edges of bone. Now, in the last 20 years, we've learned that OA is far more complex and heterogeneous than we originally thought. First off, we've learned that OA affects every joint tissue. So it affects cartilage, but also the underlying bone, the synovium, the muscles surrounding the joint. And today I will be talking mainly about cartilage, but we need to recognize that there's actually quite a bit of involvement of all tissues around a joint. We've also learned that this is an inflammatory condition. So the current definition of OA is that this is a disorder that affects movable joints. It's characterized by cell stress and cell breakdown that is initiated by micro or macro injury. And this sets up a cycle where we're just not able to repair that cellular or tissue damage fast enough to deal with the damage that's occurring. So we just have damage outpacing repair. And that leads us to molecular problems. So we have abnormal metabolism occurring in the tissues. And eventually that's going to translate into anatomical and physiological problems that ultimately culminate in illness. Of all the movable joints, OA seems to affect the knee most often, and it's probably because this is a weight-bearing joint. And the illness that we see associated with knee OA involves chronic pain and problems with mobility that lead to or seem to be linked with a greater prevalence of other chronic health conditions. And so I like to think of OA as like the canary in the mine, that it's at the tipping point where someone could end up on a pathway to ill health. It's part of the reason why it's so important to pay attention to this disease. I also would like to use this slide to point out that knee OA in particular is a very mechanical disease. So you can see the outcome of this disease kind of unfettered. Now, we normally don't see individuals with this magnitude of joint deformity. This gentleman, we would hope, would access a joint replacement much earlier in the disease course, but it certainly gives the picture of what OA can do to that joint. And so my research goals are to link how biomechanics interacts with joint tissues, joint tissue health and joint tissue damage. And then second, to use that information to improve care. And I'm really interested in exercise as a component of that. Ooh. And so to do that work, we conduct studies that essentially try to get a picture of what the forces and torques are inside the knee joint. And to get that information, to be able to make those calculations, we need three pieces of information. The first is the force that's applied to the lower extremity through the floor, or you'll see a little bit later on through a bicycle pedal. And you can see in this example of walking, there are, not sure if the cursor shows, but there are some gray rectangles in the floor. These force plates are measuring those forces that we need. The second piece of information we need is we need to follow the movement of the foot, the shank, the thigh, the pelvis. And so we use some sophisticated digital cameras to capture that motion. And you can see in the background here a silver bar, and that silver bar has three sophisticated cameras that's tracking this young lady's motion as she moves across the floor. Oh, thanks, Courtney. And the third piece of information we gather from the literature, and it's essentially estimates of the size, shape, and weight of different body segments. And so once we have all those pieces, we can conduct our calculations, and we end up with just this overwhelming amount of information that we then get to sort through. So here we have kind of a typical sampling of the type of information we can calculate with those sources. And this is a sample of data for walking. I've plotted for you here the means and standard deviations of knee joint angles, forces, and moments in 3 dimensions. I've used orange to indicate a group who have knee osteoarthritis. And I've used blue to indicate a group of healthy older adults. The main thing I want you to take away is if you look at all this information, you can certainly see there are places or biomechanics that are definitely distinct between the two groups. There are a few places where you might not really see anything big, but the challenge becomes, what's meaningful here and what should we do with it? So far, the majority of work in the literature has focused on one of these curves, and it is the knee adduction moment. So I'm going to zoom in on that particular biomechanical measure. The knee adduction moment, or CAM, tells us about the tendency for the tibia or the shank to rotate inward on the femur. So when you think about this, this is the torque that's encouraging that bow-legged alignment at the knee that we saw in the gentleman earlier. This is the torque that's responsible for it. We think that this torque represents the ratio of how much load is on the medial or inner knee compared to the rest of the knee. On the right-hand side of the slide, you can see that waveform for a group with knee OA in orange and a group of healthy older adults in blue. And on the vertical axis, you can see that CAM magnitude. And on the horizontal axis, you can see one walking stride. And on that horizontal axis, 0 means the moment the foot touched the ground. 60 right here is that moment when your toes are leaving the ground and we enter the swing phase. Now, when you take a look at this, you can see that people with knee OA have a bigger torque. They have a bigger torque mainly throughout the period where they're supporting their body weight on that leg. Now, what we typically do is take the peak value, but I want you to note that there are other differences between the OA and the healthy group. You know, there are differences in how long that torque is around, the magnitude, the shape of the curve. But so far we take just one data point, which is the peak. And so now what I'd like to do is tell you about some of the work where we've tried to pick up the baton and move it forward down the track. And really the work that I'm about to share with you belongs to all of these folks here. I'm really privileged to have worked with some wonderful trainees. And so let me share with you what they have accomplished. So a few years ago, I wanted to do something a little bit more than look at the peak value. The peak certainly tells us, you know, the maximum magnitude that the knee tissues have to tolerate. But I was curious about the total exposure. So I proposed this idea of cumulative knee adductor load. And I needed to know two things to calculate this. On the left is that knee adduction moment curve, the very same one I showed you before. But instead of taking just that little instant at the peak, I integrated the curve. So I just took the area under the curve to represent the total exposure that the knee has to that torque. And the second thing I needed to know is how many steps a person took during a day. So we used an accelerometer to track a daily step count, and we calculated the product of these two terms to give us an idea of the total exposure that the knee had to tolerate. And what did we find? So this was a bit of a flyer for me earlier in my career. And we wanted to see if cumulative load, that idea, could distinguish between people with healthy knees and people with OA knees. And on the left, you'll see this kind of new cumulative load measure. And you can see we were able to distinguish between healthy and OA quite nicely. And you could argue perhaps even better than the traditional measurement, which was peak CAM, although you can certainly see cumulative load has a lot more variability around it. So this was really nice. It was a really nice start and a really nice discovery to this new idea, but kind of who cares? It doesn't really matter unless we could actually link it with disease. So that was the next step. I wanted to know if we could predict changes in cartilage from biomechanics. And I wanted to look at the knee adduction moment as well as features like this cumulative load variable. So we took about 50 people and we followed them for almost 3 years. At the beginning of that study, we brought them through the lab and we calculated their knee adduction moment during walking, and we followed them across those 3 years. At the beginning and the end of the study, we actually took some nice MRI pictures of their knees, and we measured out the amount of cartilage from those MRI pictures to figure out what happened to their cartilage over time. So let me show you what we found. It was a really sad day in the lab, I gotta tell you. So on the vertical axis, I've plotted for you the change in the volume of cartilage on the tibia. You'll find 0 here. You know, people sitting at 0 had no change, experienced no change over the 2.5 years. And certainly we have people below that. Along the horizontal axis, I have the peak value of that CAM, and it was not a compelling relationship after, 3+ years of research. So we spent a little time looking at the data and thinking about the data, and we were so lucky to explore it a little further, and I'll show you what we discovered. That when we took that very same group of 52 people and we split them into a group with a body mass index that indicated they had a healthy weight versus a body mass index where they were either overweight or obese, we saw something really notable. What we saw is that among people who are overweight or obese, a dramatic relationship where if they had very large CAM, they saw a lot of cartilage loss. But in the people who have a healthy weight, we actually seem to see a different trend. It was not significant, but it kind of looks like the bigger their CAM, the positive relationship was there. So one key take home was that obesity seemed to modify the impact of biomechanics on knee OA, that something different is happening in people who are overweight or obese. And this became a really important concept that drove the next studies or the next set of studies in my lab. There is one other little curiosity on this graph. So the orange dotted line indicates no change. This is 0 change in cartilage. And you'll see there are quite a few points above it. Now, as far as we know, people don't really grow cartilage. So we got a problem here. Either we made some measurement errors, that's totally possible, or something else is happening. And one of the proposals we made is that this cartilage is becoming swollen, and the higher their CAM in the healthy weight group, the more swollen their cartilage could become. But we had no evidence to support that idea. So that was the next challenge for us to tackle. We needed a way to understand what exactly was happening with this body mass index element. We knew the interaction was there. We knew that biomechanics interacted with body mass index to promote cartilage degradation or cartilage loss. The trouble with body mass index is it's kind of a messy variable, right? Physiologists are going to tell you that it's a very poor representation of body composition. It's a little bit junky there. And from a biomechanics standpoint, BMI is interesting in that it reflects multiple pathways. Certainly people who have a high BMI likely have a large mechanical load. We also see evidence in the literature that people with a high BMI walk a little bit differently. So that could be part of the mechanism of why we see the interaction. But we were also very interested in knowing whether BMI is actually reflecting systemic inflammation. We know that fatty tissue actually produces inflammation. And it could actually indicate that our tissues are altered. Does it indicate that swelling of cartilage that we were suspicious of? So we wanted to know something more than body mass index. And what we were really interested in knowing was joint tissue quality. But how do you measure that in vivo? How do you know what the quality is? So we've tried two different strategies. And the first is using an MRI technique that tells us a little bit about the composition of tissue. So what you see is a very colorized MRI scan, and the colors indicate how much water is contained within tissues. So we wanted to use this technique or this sequence to see if we could learn about the composition of cartilage and answer the question about whether the cartilage is actually swollen or not. And we wanted to take it one step further to figure out if we could detect how cartilage responds to loading. So we kind of stepped slowly into using this MRI technique. And I want to tell you about this particular slide, our first study. So on this slide, it actually features two MRI scans on each of the left and the right. In black and white, we have high definition scans that tell us about the size and shape of tissues. So here we have the femur, we have our kneecap or our patella, and we have our tibia from a sagittal view, from a side view. Overlaid on top of it is this compositional MRI scan in color called transverse relaxation time, or T2. So we have this beautiful colorized image, and the color is meaningful. The color tries to tell us about how much water concentration is in the tissue. And in regions where we see purple, we have tissue that doesn't have much water. And for cartilage, this is going to be the strongest, most resilient tissue. On the other end of the spectrum, yellow indicates cartilage that has more water in it. This is squishier cartilage, and we believe that this squishier cartilage with extra water isn't going to tolerate load so well. So we have some nice scans to tell us about regional variation of the composition of the tissue. And we also decided to see if we could learn about tissue function. So we took some scans at baseline, and then we asked a group of gentlemen, healthy knees, to run. And I'm a little trigger happy with my mouse, so I apologize. And then we took some images after that run. And what you'll notice are some subtle changes in the T2 signal that we picked up. Here on the left, we've got more water-borne cartilage under the patella, and after the run, we see a change there. And we saw a similar pattern in the posterior femur. So could we use this technique to help us inform how the knee tissues respond to loading? So our next step was to combine that imaging with some biomechanical work. And what we started out with, again, 15 healthy young gents, we took a look at comparing running to cycling. So this was kind of my first step into bicycling biomechanics. What we did is take a look at the amount of force applied to the lower extremity by the ground. And you can see on the vertical axis that the amount of force during running, as you would expect, is much higher than during biking. Of course it is. Your head, arms, and trunk, that mass is supported by the seat on a bike. So we expected a much lower total force occurring on the lower extremity. And what we wanted to do was compare the changes in cartilage tissue to equivalent cumulative loads. So we asked these gents to run for 15 minutes. And the equivalent cumulative load for biking was 45 minutes. And I'll show you what we found. As you would expect, we saw a lot more T2 change after running than we did with biking. And it's important to remember this is just 15 minutes of running compared to bicycling. And so the reason why this work we feel is important is it gives us a medium or an approach where we could actually exercise people without giving a very large cumulative load to the knee. We also saw one other phenomenon in this same study. And what we found is that if we looked at that change pre-post run or pre-post bike in T2, and we plotted it against how active people are, on the right-hand side are the most active, we saw that people who were very active saw the least change in their cartilage. The people who were most active had the least change. They had the most resilient cartilage. And we had hoped that this would translate into the idea that you, just like a muscle, you can train cartilage to be resilient. We repeated this experiment with a bigger sample, including men and women, and we saw the same pattern where the more active people were, the more resilient their cartilage was. However, when we also took a look at BMI, fed from that previous study, we saw this relationship was strongest for those with a healthy weight. So people with a high BMI, squishier cartilage. People with a low BMI and lots of physical activity, resilient cartilage. We think this could be useful when we consider rehabilitation moving forward. So the imaging was super cool. It's really expensive. And so in the pandemic, we decided we were going to try one other approach to hopefully looking at joint tissue quality. And the way we approach this is looking at some soluble markers of inflammation and cartilage turnover that we can draw from blood. And could this tell us about the quality of tissues? Now, one problem here is we don't know which tissues. They're certainly not, if we're drawing blood, we don't know if it's really coming from the knee or not. So we didn't know how this was going to go. What we did is we accessed the Osteoarthritis Initiative. This is an amazing multi-site study in the United States, and the data are available for free to anyone. We took a look at this epidemiological study, and they don't have biomechanics data, but we did think we could create a representation of cumulative load by looking at body mass index and physical activity. We also accessed MRI scans of the knee from this sample. And so we were able to take a look at change in cartilage composition using T2, just like we had been doing, over a 2-year period in about 400 people pulled from this data set. Now, to represent joint tissue quality, we pulled a protein that's found in blood that we believe represents cartilage turnover. So that effort to repair cartilage when it's damaged. And the short form is COMP, or cartilage oligometric matrix protein, provided by the OAI. And indeed, what we found was that interaction once again, that if we have people with a high cumulative load and low tissue quality represented by COMP, we could predict more cartilage loss. And so these are all little kind of cross-sectional snapshots that we hope pull together to help us understand kind of a useful target for rehabilitation. So what I'm going to propose to you is that if we take a look at biomechanics, and we could have a whole other seminar on the sliding scale of bad to good, but if you just bear with me for a second and say we can identify good biomechanics. And similarly, if we could take a look at folks and their tissue quality on a range from bad to good, and what we're really aiming for in rehabilitation is to load tissues using ideal biomechanics on healthy tissues so that we can build resilience. We can create that training effect in tissues other than muscle or in addition to muscle. But if we load unhealthy tissue, even if the biomechanics look good, we still could be susceptible to breakdown. Or if we take a healthy tissue and we expose it to bad biomechanics, we could end up with tissue breakdown. So that's my proposal to you. So how do we translate this into improving exercise. And once again, a wonderful group of folks that I've had the privilege to mentor, and the work that I'm about to show you really belongs to them. But before I get to their work, I wanted to share with you, there are just so many clinical practice guidelines for knee OA. And I've shown you here some from Australia, the international community, Europe, as well as the United States. And all of them tell us that core treatment, that every patient with knee OA should receive education, exercise, and diet, amongst some other recommendations of other non-surgical treatments. But I'm going to focus on exercise for the remainder of this talk. Now, exercise principles for OA ask us to focus our treatment on functional weight-bearing exercise. That flexibility of joints is important, and while patients are exercising, we want to maintain as best possible lower limb alignment. Obviously challenging when people develop that varus or bow-legged deformity, but still we want to maximize that ideal alignment as possible, as best as possible. We want to teach patients to respect the pain, that pain is part of exercise, but 2 more points on the NPRS or numeric pain rating scale is probably acceptable during exercise. We see better outcomes in supervised programs, and some evidence that maybe focusing on one goal at a time is the best approach. So using these principles, we wanted to look at exercise and see if biomechanics could inform ideal approaches to strengthening and ideal approaches to weight management. And so I'll take you through some of our work first around strength. Now, in terms of strengthening, I've given some guidelines on exercise prescription that are present in the literature. And as we move from the top to the bottom, from healthy adults to older adults and to those with hip and knee OA, we see that the frequency of exercise should go up. We see that the intensity of exercise should go down. And we see that the dynamic nature of exercise should get reduced. And so this idea of isometric exercise being ideal for knee OA. So we wanted to use these guidelines to create an approach that would be biomechanically sound. And so what we did is we ran people through our lab and we did motion analyses on a number of different exercises. And for some of you who will be immediately savvy, we used yoga as an approach. So if you're savvy to yoga, you can recognize right away, this was the approach we wanted to use. And we chose it strategically because we thought it'd be easy to recruit people, but also because it emphasizes that isometric, very low dynamic exercise approach. What were we looking for when we did this study? We wanted to minimize the CAM, that knee adduction moment, but we wanted to maximize how much their quadriceps were working. And so along the vertical axis, we really wanted to find exercises that hit 0, but we wanted them all the way to the right here to find exercises that challenge the quadriceps. And we found a number of squats and lunges that worked well, and we developed a little exercise program using this, this series of exercises. You'll notice one with a really high CAM, anything with single leg stance. So we did balance training using bilateral postures instead. So we ran a small randomized controlled trial where we compared our yoga program to traditional physiotherapy, and we involved an attention control group. They actually received meditation. We just wanted to match the attention that they received, but they didn't receive anything physical. And we asked them to participate in 36 exercise sessions that were, or intervention sessions that were supervised. And what we found was that people, there's that mouse again, that people who completed our yoga program as well as traditional PT experienced greater reductions in pain and greater improvements in mobility compared to our control group. And you could argue, although we weren't sample sized enough, that maybe yoga even did a better job. It needs a bigger study. Interestingly, on secondary analysis, we also noticed that people who had the biggest strength gains were also people who saw the biggest reduction in their systemic inflammation. So there's that link again between, what's happening systemically with outcomes around biomechanics. Since that time, we've started working on the idea of weight management. This was inspired by that finding, or that persistent finding, that in situations where our patients are overweight or obese, that those tissues may not tolerate loading as well. The trouble is, how do you help someone lose weight through exercise without overloading their joint? Well, the current guidelines suggest that we want exercise programs for weight management to incorporate 20 to 30 minutes of aerobic activity 2 to 5 times a week, and that we're aiming for kind of a really slow, gradual loss in body mass. And so we decided that the bike would be a great approach because we're offloading the knee by using the seat. And so we wanted to start looking at biking as one component of a weight management program. And as we started looking to the literature, we realized that we needed to be careful about how we positioned people on the bike or how we guided them to seat themselves. And the current guidelines that are out there really focus on positioning the knee joint just so. But we didn't find a lot of biomechanical evidence to support that decision. And so we conducted a study focused on bike fit in 40 healthy people. We asked those 40 people to come into the lab and to bike 18 times. They had to bike for 3 minutes each. And those 18 different conditions were really variations on the saddle or seat height and the seat fore aft position relative to the handlebars. And so we got quite a bit of data from that experiment, and we fed that data into a musculoskeletal model. This is like a digital avatar to try to calculate what knee joint reaction forces occurred. Could we find a biking position, a common biking position, where we minimize joint reaction forces inside the knee? And kind of in contrary to what's being done out there in the world, where we are focusing on the knee position, we actually found that focusing on hip and ankle position was really important, such that, as cyclists would know, the more hip and ankle flexion we have, the greater the knee joint reaction forces we observe. Now, I do want to point out that the knee, the tibiofemoral joint, was actually not that sensitive to a bike fit or to variations in bike fit, but the patellofemoral joint, so that joint between the kneecap and the rest of the knee, was quite sensitive in terms of how much load that joint is undergoing, depending on where that bike seat is placed. So our next steps, I forgot I put this slide in. So we wanted to take a look at how cycling affected the tissues inside the joint, just as we had been doing before. So we asked 16 ladies with painful OA knees to cycle for us. They cycled for 25 minutes at a moderate intensity. And we took those compositional MRI scans before and after to calculate change once again. And what we found was on the femur. So we're looking at the bottom of the femur right now. This anterior portion, this is where your kneecap would sit. And this is the lateral or outside side of your knee. We saw that we had quite a bit of water squish out of this purple region. So this is the region that's taking on the load underneath the femur. And that water seems to have been redistributed to these yellow areas. And we're really excited about this finding because we didn't know where the water went. Now we do. It goes to other places inside the joint. And so what we hope to do is once we get going after COVID is to try examining whether cycling can actually help with clinical outcomes, including weight loss. But we also want to monitor that joint tissue quality. And could we actually help build more resilient tissues? So I talked a lot. Thanks so much for listening. I'm just going to give you two big take-home points. First, I hope I convinced you that we have to consider both biomechanics and the joint tissues in order to really understand OA disease and how it gets worse. And in terms of the biomechanics, I've talked to you about the knee adduction moment, cumulative load. There are other measurements out there, but we definitely see that when we apply biomechanics in the context of obesity, in the context of what that tissue quality looks like, we can understand better who is going to get worse. And second, I really hope I convinced you that we can use that information in meaningful ways, that we can use it to help guide our exercise prescription for both strengthening and weight management, but certainly we have more work to do there. So I want to thank all the lab members who've contributed to the work that I shared with you today. I have such an awesome team of collaborators who are pictured here. And we've been very fortunate to have funding to support this work. And I want to thank all of you for your attention. And I'd love to chat with you and hear what questions you have. Thanks so much.
Thanks, Monica. Wonderful talk. I was not expecting anything different, to be honest. It's really, really great. And thanks for sharing your experience. Let's have a look. I think we've got, let's see how questions come through. Does anyone have any questions or would like to take the opportunity to learn a little bit more from Monica whilst we're here?
Rodrigo, can I pick up a question if that's possible?
Yeah, sure.
Here.
Monica, thanks very much for your presentation. It's Mike Kingsley here. I'm the director of the HRI and based in Auckland. So thank you. And thank you for the introduction to the peoples of Canada. I thought that was very poignant. Thank you. I would just like to ask a question, Monica, around the final part of your presentation, really, which is, where do you see these intervention studies in cycling going, and what are you thinking about? Because I'm really interested in that part.
Yeah, I really hope that cycling could be an important component of rehab for the right patient. I think the key to exercise with OA is adherence. And so I think it really won't matter what we do, biomechanics, imaging, whatever, if they don't like it. So, I mean, I think the first and most important challenge is very much getting people to buy in and to adhere. And some of that is around comfort, comfort both physically and comfort with actual cycling. And I'm hoping that some of our work will involve knowledge translation to help clinicians and members of the community, so bike shops, bike fit professionals, to help guide that everyday person for cycling, whether it be for transportation, that's a real part of their everyday life, or for straight up rehabilitation. So I think some of it, you know, I showed you some, deeper biomechanics and imaging work, but really that first hurdle, I think, is all around adherence and getting people comfortable and safe on a bike. And then the second part is to really emphasize that in certain folks, we might actually be better off initiating exercise in ways that gradually progress the cumulative load. And so that's what I hope we will work towards in our lab, is to suggest that we do want these folks to exercise, but we do have to be mindful that if we take someone who may have really squishy cartilage that is prone to degeneration, that we should be careful about how they exercise. And there are choices out there that we can show them that here are some options that you can choose between, and that with time we will progressively increase that total load. But biking is so attractive because we offload the knee so automatically on the seat. So that's kind of where I think things are going, at least from our perspective, one around adherence, which I haven't talked about in this talk, and the other around really coming up with ideas and strategies and different approaches that people can choose from.
Thanks, Monica. And I guess I'm just interested in whether you could use some of your imaging techniques to look at pre-post, and maybe look at using those to assist us with prescribing appropriate exercise. And
absolutely, that's where I really hope to go. There is evidence that we can improve the composition of cartilage from a little bit from our lab, but also other labs internationally, in healthy joints and in joints that are at early or at risk for OA. So the question is, are we going to see the potential for improvement if we have established disease? And I think the answer will be yes. I think it will be yes if we do it properly. And so I really do hope to do some exercise trials with cycling, where we image them before and after. But I think it's a ladder, and we'll have to start slowly and move up, because that will be particularly costly. But I think it's important work.
thanks, Monica. And I guess, I'm wondering whether there's opportunities to collaborate, particularly around the link there and the metabolic, which is obviously where we have a reasonable amount of expertise in our space as well. So thanks very much. I'll leave you to others for questions. Thank you, Monica.
Well, I would love that. I would love that. I have a sabbatical coming. So.
Sounds good.
Yeah, thank you. Anything else? Anything at all?
More questions from anyone?
And thanks so much to the folks for those lovely comments in the chat. I really appreciate it.
If no one is...
Rodrigo, can I pick up a quick question?
Yeah, sure. Go for it.
Thank you, Monica. Really appreciate that. It was a fascinating talk. I guess if I can just pick up on a little bit of what Mike's question was around the cycling, and maybe extend on it a little bit as well. Is it potentially, looking at how you presented those joint reaction forces and things within the cycling, is that potentially also helping to drive some of those isometric contractions by not necessarily as much movement around the knee, and so therefore the cycling also being a form of this isometric strength training, which is potentially contributing to those outcomes that you saw? And then I guess as an extension to that, I'm interested in your choice around IL-6, of that inflammatory marker, given that we know that that's excreted from multiple tissues.
Yeah, okay. I think I'm going to try to tackle IL-6 first with a somewhat unsatisfactory response, which is I'm really lucky that I collaborate with an immunologist. She's fantastic. I approached her first with these serum cytokines like IL-6, IL-10, CRP, and TNF-alpha. Dawn Bodish is her name, really presented the idea that those are interesting, but we have some way more interesting stuff around immunological responses. So I did show you the inflammatory cytokines, but we have found some more interesting pieces around the immune response. And in particular, what we found is in our strengthening yoga exercise trial, that the folks with OA have an abnormal immune response. They have more precursors to white blood cells circulating, but those white blood cells don't seem to mature properly. And as a result, we think that their ability to respond to infection, disease, and repair is abnormal. And that work is pretty new. And so in particular, for folks who are well-versed in it, it was MCP1, a ligand precursor for CCR2 that we're trying to track, and we're tracking it now. It just didn't fit very well in this presentation, and it's not as, it's definitely not my strength, it's Dr. Bodish's. So I think the inflammatory cytokine piece is interesting, but I think this immune response is even more interesting, and perhaps one of the most exciting pieces of it is the immune response had a tighter relationship with BMI than the cytokines did. And so that's what, like, my little teaser about some of the immune work that that Dawn is doing with us. In terms of cycling, I talked so much that I might have lost your question. I believe your question was around the sensitivity of the joint reaction forces on the bike.
Yeah, and whether by changing some of those contributes to more of that isometric type contraction.
Yeah, okay, so I'm so intrigued by your question. I'm a physio, and when I was practicing clinically, I used the bike not for isometric, for precisely the opposite. I put people on the bike to increase their range of motion, especially before and after joint replacement. So in my brain, I think of the bike as a way to get more motion, not less, out of the knee. And that's kind of where I'm coming from for that. In terms of the joint reaction forces, you know, in a way, this slide is quite comical because we did just a ton of work, and the graduate student that worked on this is now just fantastic, a postdoc at Stanford. He just did a ton of work to say, you know, if you don't have your whole weight on your knee, you don't have as much force going through your knee. Well, no kidding. And so, you know, we did this in a very complex way to come to that answer. I make a joke. I mean, we did really want to know about bike fit and where to place them, but the fact of the matter is, if you take their weight off their knees, you probably can have a lot more freedom in how you load them. And so, you know, as I'm talking, it makes me wonder if part of the success of improving range of motion on the bike is because we've offloaded that joint reaction force. But yeah, I'm intrigued by your question, and I hope I've responded in a way that at least got me a little closer to answering you.
No, absolutely. And I was sitting here hypothesizing about the similar types of things. So they're very interesting to think about.
Thanks.
Thank you.
Wonderful, thank you. Any final questions before we let Monica rest a little bit? I think I might close for then. Thanks again, everybody. Thanks, Monica. We really appreciate your input and sharing your knowledge, your experience, and we hope that we hear more from your work, and then we keep communicating as we are at the moment. So, and thanks everyone, and thank you all. Enjoy the rest of the day, and yeah, take your rest.
A pleasure to join you. Thanks again for the invitation, and yeah, I hope we'll get chances to connect many times in the future.
Beautiful, thank you.
All right.